Aloha, my name is Dr. Tiffany Hoke. I am an adult gerontology acute care nurse practitioner, a certified neuroscience registered nurse, and a stroke certified registered nurse here in Honolulu, Hawaii, where I've spent most of my time in neurocritical care. I authored this abstract with my colleagues, Dr. Trevor Torigoe and Dr. Ferdinand Hui. Melanocortin-4 Receptor Deficiency is associated with cerebral venous congestion and intracranial pressure disorders. As experts, we have observed that cerebral venous congestion and intracranial pressure, ICP disorders, are associated with hypermobile mixed connective tissue disease, mast cell activation syndrome, or MCAS, and metabolic syndrome. Yet few case reports link these overlapping phenotypes to pathogenic mutations on genome sequencing or present sustained relief to treatment. Our case with a 38-year-old female with 14 years of progressive relapsing and remitting, migraine, facial pain, multifocal cranial neuropathy, vestibular dysfunction, cervical dystonia, cognitive impairment, dysautonomia, and activity intolerance. Her medical history included obesity, hypermobile mixed connective tissue disease, MCAS, polycystic ovarian syndrome, uterine ablation, and poorly differentiated thyroid cancer with angioinvasion. Lumbar puncture confirmed intracranial hypertension, or IH, and venogram revealed bilateral internal jugular vein, or IJV, compression that was complicated by bilateral venous thoracic outlet syndrome. Weight loss of over 170 pounds and max dose acetazolamide offered limited benefit, so she underwent staged bilateral SEV decompression with temporary improvement, followed by spontaneous intracranial hypotension with left accessory nerve palsy. She then underwent left IJV decompression and ethmoid cerebral spinal fluid CSF fistula repair with temporary improvement again, followed by rebounding hypertensive hypotensive intracranial pressures, or ICPs, with right sphenoid wing CSF fistula, worsening cerebral venous congestion, and ophthalmoplegia. Thankfully, a left IJV stent resolved her ophthalmoplegia immediately. She underwent a right IJV and cranial nerve decompression with fistula repair yet again. That course was complicated by an intermittent right vagal nerve palsy with ICP lability and fistula recurrence. She was referred to genetics now for maternal history of a parallel course progression, complicated by her mother's suicide at age 44. Multiple maternal family members shared overlapping phenotypes. Whole exome sequencing revealed an autosomal dominant, complete loss of function, monogenic melanocortin-4 receptor deficiency that inhibits binding of alpha melanocyte stimulating hormone to deficient MC4Rs throughout the autonomic nervous system, leading to severe hyperinsulinemia, insufficient hypoglycemic counterregulatory response, impaired mast cell apoptosis, hyperphagia, and hypothalamic obesity. Continuous glucose monitoring went on to reveal severe hypoglycemic unawareness, occurring nightly between meals with fasting and exertion as low as the 30s, associated with symptom provocation. MC4R deficiency impairs carbohydrate metabolism through deleterious alteration of paracrine signaling, leading to neuronal inflammation, increased body mass index, facilitating venous compressions, and IH. The patient transitioned to a whole foods, low histamine, modified ketogenic diet supported by holistic lifestyle interventions with marked amelioration of her symptoms. Her cerebral venous disorder symptom severity scale improved from 23 at disease severity to now 12. She currently has persistent bilateral hearing loss, provocative cranial CSF fistula, facial nerve palsy, and left nutcracker symptoms, and is scheduled for a right IJV stent next month. She may go on to have possible left renal vein intervention. So, the monogenic neurometabolic syndrome of MC4R deficiency is associated in our patient with cerebral venous congestion, ICP disorders, and hypoglycemia with reversible deficits. It presented an autosomal dominant familial phenotype with features of hypermobile mixed connective tissue disease and MCAS. Medical and surgical therapies were beneficial in treatment of her acute exacerbations, but dietary therapy supported by holistic interventions were critical for sustained relief. And if you haven't figured it out yet, that patient was me, that mother was my own. And I wish to thank all of you for being here today in the years past, for collaborating together so beautifully to offer me a second chance at life. Without you, I would not be here sharing with you all that we have learned and the wonderful news of my recovery and progress. Thank you.